Good afternoon. It's nice we can all get together again. We've heard from some of you that these are valuable, and I'm so happy that they are. It's good for us to be able to share some of the things that we know that's going on as well. So I really want to thank everybody for coming and joining us with this. We've had, I think, over 1,000 with each one of these. I think we started out by the time we got the button pressed today. We had almost 400 people on this, and I know everybody's busy and everybody's concerned, but we want to thank everybody, not just for joining us here, but thank you for everything that you do to support our patients, their families, the communities we're privileged to serve, and for supporting each other. Our agenda today, we want to talk about predictive modeling because as we work our way through COVID-19, a lot of the decisions that we're making are based upon models that are very well established models that allow us to say, how many patients can we anticipate? When is the peak going to be? How will we know when we're ready? And so what we're going to do today is I'll first give an overview on that. We'll ask Dr. Sarah Manny to give the introductions of her team, and then we'll go how these models actually work. I'll give a little bit of background about that first. And then we'll give a demonstration of the models so you can see how those models are playing out as to what we're seeing here across Essentia land. And so you can see how we're trying to predict the future with the models and some of the strengths and the weaknesses with the models as we go forward. So I'll push right ahead here. Normally we spend about 30 minutes, but there's just so much in-depth information that we can use on this model. I will give a little bit of background here. We may take more than 30 minutes, maybe as long as 45 minutes. I know that I got some emails that said things were, my face was real dark the last time we tried to work on the camera, but you know, when you're sitting in Duluth and the sun finally shines in Duluth and it lights up everything in back, it's something that we weren't ready for the last time. So why are models used? Models are helpful when there's not a known source of truth. So I can tell you that Independence Day occurs on the 4th of July every year because that's something that's scheduled. That's a source of truth. But when we talk about when's the peak going to be with COVID-19, there is no source of truth. It's something that we have to anticipate. So we don't know exactly what will happen in the future, yet these models are useful for allowing us to provide scenarios that allow us to say, well, if it's going to be this on this particular day, here's what I need to do going forward to be ready for that. So these particular models really help us with timing, and they help us with peak cases. What can we anticipate if the conditions, as said in the model, continue to persist through the model? So how does it work? So the models really make estimations based on what if scenarios. So a what if would be, so if we hadn't done social distancing as we've been asked to do in the state of Minnesota, what would it look like? What could we anticipate if we did social distancing? And this was one of the factors that the governor and the government used to impose social distancing on the state of Minnesota. These models are not just what we call a de novo model. They're based on prior experiences in other locations. So we can learn from the experiences of others and build those into our model. We also need to know a lot about the characteristics of the virus and its spread. And that's something that's a lot easier for influenza virus, where we know it very, very well, than it has been for COVID-19. So we are learning as we're going forward and building those learnings into the models. And then there's a difference between the characteristics of the virus and the characteristics of the disease. The virus has certain properties that allow it to be transmitted, but characteristics of the disease are also based upon, well, how many people to get infected from each infected person? Are there ways where we can treat this, as we're finding out, interestingly, that normally when you're on a ventilator, you do much better when you're supine or on your back. It seems that a significant number of patients benefited from being placed prone, face down, on the ventilator. So these elements are projected into the future for resource planning, knowing that if I keep my patient on his or her back, they're going to be in the intensive care unit for 15 days and on a ventilator for 6. If I place them prone, they may only be in the ICU for 13 days and on a ventilator for 4. So we can start to build these into the models. What's our goal of sharing this information? Our ask on this would be, number one, this will be very interesting, but we want you to be engaged in this. We want you to be able to see this and do your best to understand this. We also want you to come away with that there's an understanding of the uncertainty. This is almost like predicting the weather. We can, with a high degree of certainty, tell you what the weather is going to be like tomorrow. But as we move forward into the future, that uncertainty becomes less. So using the 4th of July analogy again, we know that the 4th of July is very, very likely to be warmer than Christmas, but we can't tell you whether it's going to be 80 degrees or whether it's going to be 65 degrees. And then what we want you to do is to understand why we're planning what we're planning and to work with us with actions to support the response of Essentia Health to be there for our patients and there for our community as we work our way through COVID-19. So what are the characteristics of COVID-19? This is a disease that causes primarily respiratory symptoms. But as we're finding out, those symptoms can vary very widely. Some of the patients that will become infected with COVID-19 may not know that they are infected at all, but a certain number of patients will require hospitalization. Some of them will require ICU care, and unfortunately, some of them will not survive the disease. Even now, as we're learning more, the relative proportions of those are unclear due to lack of testing and other challenges that as a society and as a world, we're just coming to meet. We know that it's spread by person-to-person contact and it's very contagious. So social distancing, staying away from each other, wearing the masks, not congregating at ball games or concerts is an important strategy to reduce that contact. And we can see, and some of the data will be shared with you today, we can see how social distancing has slowed the spread, pushed out the peak, and I think really given us a lot more time to be prepared for this in the state of Minnesota. The principles of the modeling are based in science, and communicable diseases have been modeled for many years using what's called an SEIR model. The S stands for susceptible. How many people within a population haven't had the disease, don't have an immunity to the disease, and are susceptible to the disease? The E stands for exposed. How many people were exposed to that disease? The I stands for infected, and the R stands for recovered. And these models have been validated in a number of diseases, not just viral diseases and not just COVID-19. And they are useful in providing predictions in the number and the severity of the disease going forward. And it's these types of models that we're employing to help us understand what we can anticipate for the number of patients being sick and when we can anticipate that happening. As I mentioned before, all models are subject to assumptions. The best way I can do is anyone who's planned food for a wedding or other gathering knows that you make assumptions based upon the RSVPs that you get. You know that some people will RSVP and not show up. You know that some people won't RSVP and do show up. And understanding your family or your friends gives you an idea of how many meals to prepare. And we're familiar with weather models where predicting the temperature 3 months from today is nearly impossible. But these models have some of the same complexity that the weather model does, or something as similar as planning for a wedding. And so within these models, there are assumptions that are defined and then assign numerical values that drive the results of the model. So the Minnesota model is a model that the Minnesota health systems have agreed to use and got together under the aegis of the Minnesota Hospital Association. And we've picked this model because it's very similar to most other models that are out there, and it's readily adaptable for operations. And by that, I mean, on a health system by health system basis, it helps inform our planning decisions and timing. And also, we're very fortunate here at Essentia that we have experts from our enterprise analytics platform and the Essentia Institute of Rural Health who also developed modeling tools that take into consideration our very unique patient demographics and geographic locations and produce similar results to the MHA model. So those models validate each other. We're able to compare one to another and try to discern why one is different than the other, but they're all what we would call directionally similar. They're showing an increasing likelihood of being infected, an increasing likelihood of being infected within the community, and also showing us a good time frame when the peak can occur. I'm not going to take the time to go through all these model elements, but as you can see, the percent social distancing effectiveness in there. Was canceling elective surgery the right thing to do? What does knowing the patient length of stay give us as a predictor for how many beds and how many ventilators we will need. And then there's phase 1 surge capacity, phase 2 surge capacity, and likely when we look forward in this, this is not a single event that will come and be gone. Until a vaccine is developed, until we are really good at testing and doing other things, there are likely to be waves of this that come through the population and come through Essentia that we will need to be prepared for. So with that, Sarah, Dr. Manny, I will turn it over to you to introduce your team.
Great. Thank you very much, Dr. Herman. I'm very pleased and very proud to be working with this great team of scientists from the Enterprise Analytics Group and Essentia Health Institute for Rural Health. So I'd like to introduce Krister first. And Krister, you can introduce yourself and your team, please.
Great. Thank you for having me here today. My name is Krister Madsen. I'm the Director of Enterprise Analytics here at Essentia Health. I want to stress again, like everyone else has, the great work and the collaborative work that we've been doing with the Essentia Institute for Rural Health and Enterprise Analytics. We have two members of our team here today, Niall Klein. Niall is a PhD level data scientist here for Essentia Health, and Elena Wilmot. Elena is a senior business intelligence analyst. Could you introduce yourselves quick?
Absolutely. My name is Niall Klein. I'm a data scientist housed in the Enterprise Analytics Department, working with Krister and Dr. Manny. And I'll be talking us through a bit of the Minnesota Hospital Association model in just a moment. Elena?
Yeah, thanks, Krister. My name is Elena Wilmot. I'm a business intelligence analyst in Enterprise Analytics, and I will be showing after Niall some more regional short-term projections.
Fantastic. And Steve and Daniel, please.
Yeah, sure. I'm Steve Waring. I'm the principal scientist at Essentia Institute of Rural Health and an epidemiologist, and just really proud to be working with this great team on this very, very important problem for all of us, especially our patients in our communities. Daniel?
Hi, I'm Daniel Simon, and I'm a research scientist and epidemiologist at the Essentia Institute of Rural Health.
Wonderful. Thank you very much, team. We're going to start off with Steve giving a little bit of discussion about models in general and some general thoughts before we show the demonstration.
Sure. Thanks, Sarah. Basically, the models, by now, I know all of you have seen quite a few models in the paper and the news, as well as in our presentations. There's two basic models that we use in epidemiology, especially for infectious disease. But the real goal here, like in all of our epidemiology studies that we do, is we're trying to find the most reliable estimate of truth. As Dr. Herman says, that's not something we know of, particularly about something like COVID-19, since it's new. We've never experienced this. So we rely heavily on the precision of the things that we put into those models, and we call those inputs and assumptions, and we start off with basing our assumptions on wherever the best information is out there. Many times it's not our information, so we have to rely on other information and hope that it holds true. But as we move forward, we get more and more precision in our models because we're able to use more and more of our own information to inform all the things that the model needs to help us plan for. And so in doing so, we're actually, although we talk about COVID days being much longer than calendar days, we're not that far into this unfortunate exercise that we're going through. And so as such, we learn more every day about our models that we didn't know the day before that, or last week. But we do things with models where we're constantly trying to make sure they're making sense, and we've got everything in our model that we need to. And so as we have begun to investigate our models more and more, we're finding that they're coming pretty close so far. Obviously, because we're relying more and more on our own information, we feel like it's a good representation of what's going on locally that may be different than even what's going on in the Twin Cities, much less New York City and other places where this is running rampant. And the other part that we want to talk about in terms of, as Dr. Herman alluded to, the main model that we're using, a lot of people use the SEIR model. Those are called compartment models. And what they mean is that you put people into one of those four bins. Now, there's also models that are SIR. They just leave the exposed part out, and they just make some assumptions on the interval between exposure and actual infection. And so both of those models are compartmental models. The other primary model that you see out there, which is the University of Washington model, is a curve fitting model. So that curve fitting model is based on statistical processes, and they're creating confidence intervals around that. So just when you're looking at any model, you want to know, well, what are they basing it on? What are their methods? And what are those confidence intervals telling us? Or in our case, we just do different scenarios to come up with, well, if it's a low spread, it's this. If it's really high spread, it's this. So you get an idea that somewhere in between those outlined lines is probably what's going to actually happen. But again, we can't really predict 2 months down the road. We can just predict that it's probably going to be a little bit different than it is now based on where the curve's going exponentially up. And I think Elena and Niall's models would probably support that.
Thank you so much, Steve. I really appreciate that. We do have some FAQs about the models, and so those are located on the COVID tile, and we'll also send that out in the COVID update tomorrow. It may help answer some questions that you may have. The last thing I'd like to say before doing the demonstration is it's very important that you be aware of your own feelings before we go through this. We have found when doing this presentation that it can sometimes bring up some feelings that are unsettling. So it's normal to feel some sadness, some anger, and a little bit of shock, because we will show you what the peak appears to be. We want to stress that this model should be considered directional. There are so many factors going into it that will affect when and where that peak will occur. So with that said, I'd like to turn it over to Niall. Thank you very much.
Thank you very much, Dr. Manny. We will switch to sharing my screen here just a moment. So as Dr. Waring mentioned, and Dr. Herman, Dr. Manny indicated, we're using what's called an SEIR model. And I just want to spend a short little time on what that means for us and why it matters when we go through this model. The first bit is that this is really trying to model the dynamics of the disease as it moves through the population. So how is it spreading within different subgroups of our area and our different markets? A lot of the models that you're seeing out that are published in papers or on the news media, we're going to look at it at a state level or a country level. And with this particular SEIR model, we are actually using smaller populations, getting down to a regional level that we think will help us with our operational planning. So the region that the current SEIR model uses is defined by the Dartmouth Atlas project. It's something called a hospital referral region. And as you can see, so for instance, our East Market would fall into this Duluth population, West Market would fall into this Fargo, Moorhead population. And what that allows us to do is see some of the differences in how this virus is spreading in our communities. So we know, we're hoping, that New York has maybe peaked, given the strict social isolation and distancing that they're following right now. They'll hopefully continue to fall for a while. But obviously, Minnesota is probably only just ramping up, and that's largely driven by the Twin Cities. So this allows us to get at more regional and localized models. Now, this SEIR model, this susceptible, exposed, infected, recovered, depends on a number of estimates and assumptions that we have to put in. One is how many people are susceptible. And as we've indicated, given what we know about the virus, our current assumption that we put into the model is that everybody is susceptible who has not yet been infected with the disease. We don't know that that's true, but again, because this is a new virus, we think that's the most likely. We need to come up with estimates for how long someone is sick and how transmissible the disease is. So I think you've seen ranges of 14 days or so when we come to how long an infected individual is transmitting the disease. We need to know how long the incubation period is. So how long does the virus need in a body before it starts being transmitted on average? So we take some of these estimates and we build that dynamic model, the movement of the virus, the spread of the virus through our community. And then on top of all of that, we need to also have estimates of, well, how many of the infected individuals require hospitalization and how long do they need to be hospitalized? How many require ICU level care? How many require ventilated care? So there's sort of two layers here of modeling that's going on, all where we use estimates, as Dr. Waring was saying, we use the best available estimates we have. And as we gather more local data, the Minnesota Hospital Association CMIO meeting, of which Dr. Manny is a part, meets regularly to discuss the best and up-to-date data we have, and we can revise some of those estimates and improve them and get to a better estimate of what we might actually see in Minnesota. So here's our population, and I'm going to take us over into one example of a localized view. Now I've selected the facilities in Duluth for Essentia. That's where I'm based, St. Mary's and what used to be the Duluth Clinic. And this is the Minnesota Hospital Association model, the different parameters that the group has agreed on. And again, it's powered by the Q Ventus organization out of California. I do want to point out here, we're showing this way to sort of allow some dynamic changes and show off a few different things for you all. This isn't necessarily the view that the leadership is looking at every week when they look at the output, but it lets us do some fiddling here that I think might be productive. So the first thing we want to call out are some of these assumptions about the virus and the spread of the virus in our community. And one of the most important and the one that we see changing most regularly is this daily infection growth rate. This is also just, you can think of this as the doubling time. So the most recent agreement with the MHA was that for Minnesota and for our regions, a 7.8-day doubling period is probably the most accurate assessment we have. This is one we've seen change. We were doubling more quickly, and that was going to mean the virus is spreading through our community more quickly. But with the stay-at-home order, with social distancing, we've seen this extend, and that pushes that peak out, and I'll show you what that means in just a minute. That pushes that peak out and flattens it. Another important one is the percent of infections being reported. As we know, there are severe testing limitations within our organization, not just within our organization, within our country. And so we have to use some estimate of how many of the infections we're catching with the testing. And obviously, as we expand testing, hopefully this number will go up, but it's an additional layer of uncertainty. So those are really helping us drive some of that SEIR model. And then from there, we need to make those other estimates on how many of the infected individuals require care and how long they need care. So just very briefly, we're assuming non-critical care for about 3.8% of everyone who is infected, and a length of stay of about 8 days. Obviously, this is going to really matter to our load on our hospitals and our facilities and our staff and the PPE required and everything else. How long are they going to be in our facilities? An additional 1.53% we think might need ICU level care with a correspondingly longer length of stay, and 1% or so requiring ICU care with vents, and again, a 14-day length of stay there. And this is a subset, so these two add up together. So we use some of these estimates. We use the current known cases that get scraped from online. We use our population from our area. We also have our market share built in here so that it's giving us actual estimates for the facilities that we've selected. And then we do this for every facility in our system. And the output that we get is a predicted census on a given day, going out as far as we allow the model to go out. It defaults to 45 days. So right now, for instance, it's saying med-surg level census here in Duluth of about 5 beds. And this is that point in time, so it's not cumulative. And we can see how it stays relatively flat at the moment out until around May 4th, which is when the stay-at-home order is due to expire. We don't know what's going to happen after that, but our current assumption within the Minnesota Hospital Association is that there will be some relaxation of the stay-at-home order and social distancing, and that will drive a slight increase in how quickly the virus spreads through our community. So we can see as this ramps up, with that reduction, the sorts of volumes and census numbers we might expect. Now I want to focus in here again that this is a directional model. We're getting precise numbers, and because we get these precise numbers, may lead us to think they're extremely accurate. But those of us who have been looking at this model day after day, or looking at the Washington model or any of the other models, know that there's big shifts. And the way I was just thinking about this today was that these shifts, it's sort of like trying to predict traffic a few months out, not knowing where they're going to put in traffic lights or how mass transit is going to be put into place, right? So these shifts in social and public policy and in how we all are interacting have huge impacts in what we see from the model. So here we're looking all the way out 45 days into early June. We look at a projected census of 59 for med-surg level beds, ICU at 18, and ICU with vents at 13, and this is just in the Duluth facility. So now I'm going to shift this out so that you can see the whole curve as it currently exists. Before I do that again, I want to emphasize this curve shifts massively with every change in these estimates. And it's both because we're learning more, and it's also because of those public and political decisions that are made within our regions. So take this with a cup full of salt. Click all. So now you can see what we think of as, or what you might hear described as the peak. We know it's extremely likely that the peak is not the one answer. Maybe it'll be multiple peaks, maybe it'll come in as a plateau. And again, those types of realizations are not necessarily due to the modeling, it's what we do as a community. So just for the sake of demonstration then, we'll pick around the end of July, and we'll look at these numbers, and then I'm going to shift things for you here because these are all estimates and the estimates change. So currently projecting 625 or so med-surg beds on this particular day. I'm going to go up into my scenarios. And after the stay-at-home order is changed, our expectation currently is that the doubling period will go to 5.8 days. But our doubling period just a few weeks ago was closer to 4 days. So again, here we are, end of July, 625 beds. I've changed the doubling period, and we can see what the result is. So now we've gone up to 880 beds, and that peak has shifted forward several weeks. What happens if we go to the type of doubling period we're currently seeing? So somehow we maintain the amount of social distancing, even knowing that the stay-at-home order is likely to be changed. That pushes that peak all the way out into late August and dramatically reduces that census count. Now, these all seem at this point to us to be plausible scenarios, and we're looking at these different scenarios and looking at other models when we present these kinds of numbers and changes to leadership. So we wanted you to be aware of all the different estimates and uncertainty that go into this, but also how it can be useful for operational planning. And as we go through and consider all of these estimates and revise these estimates every week, those numbers are then fed to the IMT committees and fed to the surge committees so that they can complete their operational planning. I think that's what we'll talk about now for the Minnesota Hospital Association model. Krista, would you like to introduce, or Dr. Manny would like to introduce the other regional and comparison model?
Sure, thank you. Again, this is Krista Manson here. So Niall showed some of the changes that were happening with that doubling time and how dynamic some of these models are. I'm also going to bring Elena up now, just because we're monitoring those kind of short-term projections and making sure that we're falling in line of what we're seeing on the ground, because they're so dynamic and they are changing. We need to make sure that we're up to date on those. So Elena, could you pull up your short-term projections, please?
Yep, absolutely. Okay, so as Krista mentioned, this is intended to be a bit more of a regional snapshot where we're currently at in terms of the cases that are reported at the county level in our area. And what's useful is, like Dr. Herman said in the beginning, we can try and compare ourselves to other regions, maybe of similar size, similar geographic area, or regions that have been experiencing this outbreak for a longer period of time. so that we can get a sense of how we're doing in comparison. And so this graph, the map in the top left here just shows the number of cases that are currently reported. And this is as of yesterday. So every day we grab data from the previous day from New York Times. So we're always displaying the most up-to-date information that we have at the county level. And so this is for North Dakota, Minnesota, and Wisconsin. The top right here, we can select one of our markets. So I have the central market selected right now. And we can see how we're trending compared to a comparison location. So here I've just chosen Rochester, Minnesota. And we can see how we have been doing since day 0. So what we are defining as day 0 is the first day that a particular location has at least 10 cases. So this has been a pretty consistent way of being able to compare these time series lines together. So we can look at how our trajectory with COVID-19 in central region or central market has been comparing to Rochester, Minnesota, maybe Madison, Wisconsin, Spokane, Washington, or we have a handful of states here who have been experiencing this outbreak for a longer period of time. If I go to the East Market, which I'm also located in Duluth here, so we can see the East Market has been tracking pretty consistently with the experience of Rochester. If I flip it to the West Market, we can see the West Market has actually been growing at a bit faster rate than that of Rochester. Another way of looking at this is, let's say we wanted to understand what the stay-at-home order, if it had an effect on the number of cases or the potential growth rate. We can show those cases, instead of looking at a day 0 here, we're looking at the days since the stay-at-home order was put into place. So for each of our markets here, they're all shown together. We have West, East, and Central are showing the Minnesota stay-at-home date. And again, the red line is Rochester, Minnesota. And so we can see how, since that stay-at-home order went into effect for the state of Minnesota, we can see how our different markets have grown in their number of cases. So stemming from that, in the bottom left corner, we wanted to understand what it would look like if we could take the experience from some of these other regions and project it to our population. So if we were to grow at the same rate as one of these locations, this is what this might potentially look like. So here again, we have those similar regions: Madison, Wisconsin, Rochester, Minnesota, and Spokane, Washington. If we had grown at the same pace as they were, this is what this might look like for us. And we can see again, if we switch to East Market, we've actually been growing at a slightly slower rate than that of Rochester, Minnesota, which is good. Another way of looking at this is the doubling rate. And we can see here, thankfully, we have not been on a 2-day doubling rate. So the doubling rate, as Niall mentioned, is essentially the number of days it takes to double the number of cases that you have. So a larger doubling rate is a good thing in this case. And we can see here, I'm actually going to have to remove the 2-day doubling rate because you can hardly see where we're actually at, which is much higher than that. So a much higher doubling rate, which means that we're growing our number of cases slower. So if I just go back to those regional growth rate projections, the last bit of this is to say, if we were to assume that 15% of those cases ended up in the hospital, this is what that might look like in terms of the cumulative number of hospitalizations over time. So if we were to grow at the same rate as Madison, Wisconsin, for example, scaled to our population, we might expect 63 hospitalizations by April 28th. And again, we can kind of play around with this hospitalization rate to see if we had a higher rate of hospitalization, what that might look like, lower rate of hospitalization, to get a sense of what we might be able to expect in the short term. Is there anything else, Krista or Dr. Manny, that you wanted me to highlight here?
No, I think that looks fantastic. Thank you. Krista, is there anything that you'd like to comment?
No, thank you. I just, when we first started out this project, after the stay-at-home order, we have seen that have quite of an effect on some of the rates that are happening. So I do think that I just want to give a shout out to folks that are, heeding to those guidelines and making sure that those social distancing practices and effects are recognized.
Thank you. We do thank you for sitting through this longer introduction. We wanted to make sure that you had a full picture. We will continue to give updates in the regular meetings going forward here. So thank you very much, team. And Dr. Herman, I'll turn it over to you.
Thank you very much. And as you can imagine, everyone, a lot of work goes into this. And we're using this literally every day, trying to figure out, where are we and what can we do differently to, is my screen shared? I don't
Not
see
yet.
where it did. Okay, share. All right, it doesn't want to do that. Share. So I don't know if it came up yet. I don't get not getting the red light that I usually do, Kim.
Yeah, it's
So-
it's still on Elena's desktop, but we can sure see
Okay.
you, and you can continue if you would
Okay,
like.
so I'll continue. So we know that this will change. As we've been pointed out several times, how it changes, a lot of it depends upon our behaviors as a society. If we continue to maintain the social distancing, if we can continue to be careful in the way we handle ourselves and staying 6 feet away, it has a tremendous difference in the model and our likely outcomes. So we will continue to follow this, and we continue to change the model as we gain more experience with it, so it more readily reflects what we're experiencing as a society. How well has it predicted it so far? I can say that on Monday of this week, what was predicted several weeks ago for Monday of this week is exactly what we had. Some of that's luck, but it also gives some validation to the model going forward. So what we will do is we will continue as this model changes, as we get closer to the peak or closer to the surge, we will continue sharing this. Any specific updates that happen, we will share those with you. And so we'll continue to have this conversation. And again, I want to thank the team for spending their time to help us understand this better and help us make these predictions that will prepare us better for the surge. I also want to thank everyone who sent in questions. We are looking at those questions. We are preparing answers to many of the questions that you sent in on Friday. So join us on Friday at noon where we'll go through some of those. But we want to take this very, very seriously. Again, as Dr. Manny mentioned at the beginning of this presentation, there is an FAQ section on modeling out there on the COVID tile. For those of you that have an additional interest or additional questions, I'd suggest you go out to the tile and take a look at that. Again, I want to thank our teams. I want to thank everybody for joining us. We'll continue to do these. We will continue to bring information forward as it becomes available. We would like you to do your part and reach out. We send out a note every day, 5 days a week, as to what's going on with COVID. And please take advantage of that. The communications team is working incredibly hard to make sure that we can all keep up to date with what's going on, so we can know what's going on in the organization and in the communities we are privileged to serve. So again, I want to thank everybody, and we'll see you back Friday, April 25th at noon. Thank you very much.
Thank you.
Thank you.